Hello and good evening, everyone. It's 8 p.m. UK time. So, as you know, it is definitely time to start our live event tonight. And as you can see, we have a special guest, one of our special guests once again tonight, as this is our second webinar tonight. And as you can see, Dr. Femi Olarogun is with us already. Hello, Dr. Femi. Please let me
Hello
know
there.
that you can hear me. Excellent. Thank you so much.
I,
And well,
I can hear you.
I am very excited to have you back with us. This is your second webinar with us. So thank you so
That's
much for
right.
joining once again. And how are you
Pleasure.
feeling today?
I'm good, thank you. It's good to be here. Thanks for having me over again.
Thank you so much for again joining us. And we are connected right now to Cape Town in South Africa. So thank you already for your time. I know it's a bit late for you. So I am very, very excited to have you and to listen to
Yes.
what you have prepared for us tonight as
Yes.
well.
All right.
And just let me tell you briefly that all those stronger together all those stronger together events have been brought to you thanks to our ambassadors and partners. And as always, I want to thank them for their support from the very, very beginning since we started. It was in March, back in March, when the first lockdowns, first COVID situation started. They have been supporting us and they are still here supporting us. So thank you for their help. That's all. And as you can see, we do have a very interesting topic for tonight. And Dr. Femi Olarogun, he is the actual reproductive medicine surgery subspecialist at HART Fertility Clinic, which is, as I've mentioned, located in Cape Town. And Dr. Femi has prepared the topic on the role of the endometrial cavity in IVF. So, of course, he will start with his presentation on that topic, and afterwards, it will be time for your questions. So, all you need to do is just type those questions in the chat section so that he can help you out with some of them. And, well, I believe it is time to start with the presentation. Dr. Femi, are you ready to begin?
Yes, we can start. Yes.
Wonderful. Thank you so much. Then go ahead.
Thank you. So, my brief over the next sort of 20 minutes is to try and explain what the role of the endometrial cavity is. Quite often, when we do IVF, we concentrate on what happens with the embryos, which is obviously the main thing. The quality of the embryos, which depends on the quality of the oocytes themselves and the quality of the sperms and what nature of the embryos we're getting. Um, but it's also important to know that there's a second part to the whole thing. So, if you're good embryos, you have to have a good endometrial cavity or a well timed endometrial cavity for success to happen. And it's often overlooked, the endometrial cavity as that part of IVF. So I thought what I would just do is to try and shed some light on what could go wrong as far as the endometrial cavity is concerned and what we could actually watch out for. As it has been mentioned, I'm based in Cape Town. Cape Town at the moment is back out of the whole sort of lockdown situation. So our COVID situation is improved a little bit. The numbers are not rising the way they were rising before. So we're quite hopeful that we can avoid a second lockdown as it is happening in other parts of the world at the moment. And we're hoping that once, things normalize where you're from, you can always find time to come and visit us, in Cape Town. There's so much to do, whether it's, for scientific purposes or for just for leisure. There's just so much to do in Cape Town. So you're always welcome to come down here. So, as we know, IVF has become sort of mainstream across the world. Over 7 million pregnancies have been achieved worldwide with IVF. That's a staggering number when you think about it. So, it's obviously something that happens every day. It's become part of our lives, is what we do. Uh, Success rates have increased with experience, since the birth of Louise in 1978 by IVF. Since then, so much has happened. We've been able to increase the success rates by doing things differently, improving the culture media so that we have better embryos. But it's got to a point where that's probably stagnated in terms of success rates not being higher than where they are at the moment. And one of the things to probably think about is there something we can do with endometrium that could make it different? And people are sort of working along those lines to see if that could happen. ART, which refers to IVF along with ICSI, usually now accounts for between 1 and 3% of live births in the US and Europe. Those figures are probably not as high in Africa and other parts of the world, or maybe they are, we just don't have those figures at hand. But they definitely form a big part of what we do. I mean, if you look around, a place like Cape Town, for instance, there's probably about maybe 6 or 7 IVF centers. If you're looking at places like Joburg, even more, that's in Johannesburg. So just in South Africa alone, you have, quite a host of IVF centers, and that happens all over the world. So IVF has come to stay and is obviously integral to what we do. But the problem is that it's expensive. Most medical aids do not pay for IVF. So it comes out of the pocket of the patient, as we all know. So it's, and it means that you go to forgo some other things to try and have your IVF done, which makes it, quite a difficult sort of decision to make sometimes. And when it fails, or it fails recurrently, then there's obviously, apart from your pocket being hit so hard, there's the emotional consequences, and relationships get into trouble, and people, sort of have, lots of issues that stem from the fact that, you've had recurrent IVF failures. So it's important to try and, sort of try and do what we can to try and prevent this. So when we're looking at IVF and what could lead to IVF failure, there are a number of things, that we need to consider. The ones I've mentioned already. So poor embryo quality, that usually is due to the age of the patient. So, at the age of 41, 42, the quality of the oocytes that we get is not as good, and beyond, is not as good as what you would get if you were in your mid-20s or late 20s, for instance. And the ability for that oocyte to form a competent embryo that then implants and go into normal pregnancy is affected, based on age alone. So that's probably the biggest factor as far as poor embryo quality is concerned. Obviously, the semen and the sperms also make a difference. If you've got very poor sperms, it does affect the quality of the embryos that we do get. And then poor stimulation. But, this is probably not so common, because most laboratories in the world have a standard way of doing their own thing that they've gotten perfected with time. So the stimulation protocols have obviously improved significantly. But if you don't stimulate well enough, or you overstimulate the ovaries, then you have an endometrial cavity that is not going to work so well, which we'll talk a bit more about just now. And that could be a problem as well, as far as, IVF failure is concerned. And then the laboratory itself. So, if you've got canals and you have the laboratory that is not fully functional, or perhaps does not pay attention to some detail, you might find that the embryos do not grow in optimum condition, and then you tend to have poor embryos, with that. And then the second point there is the endometrial receptivity, which is what I'll be talking about a little bit more today, which is talking about the endometrial cavity itself, the endometrial lining, which is the lining of the uterus, as well as what could be within the uterus itself that could potentially affect what that lining is doing, or even factors that are outside the uterine cavity that could influence what happens within the endometrial cavity. So there could be a thin endometrium, which traditionally has been thought to be associated with a low IVF success rate, altered expression of adhesive molecules. You need those molecules to work properly to allow implantation to happen. Then submucosal fibroids. Fibroids are very common. We'll talk a bit more about this later. Uterine septum, and then an unfavorable environment, talking about things like hydrosalpinges and infection. So that's where the talk today will be concentrating on. And then the third part of why IVF fails is because of poor embryo transfer technique, either because the physician involved is relatively inexperienced, and you go too far with the catheter, touching the fundus of the catheter, of the uterus rather, when you're putting the catheter through. And then lack of, in some units, very, very few units don't use ultrasound. Most people now use ultrasound when you're doing embryo transfer. But if you don't, you are basically going blindly to try and tell exactly where you're going, and that might be a problem as well in terms of success rates. So what about endometrial preparation for implantation? So this comes with when you're doing an IVF cycle. The initial phase is stimulating the ovaries to get follicles and then eggs. At the same time, the endometrium is being prepared, and then you introduce progesterone later on before doing the embryo transfer. Now, it's been found that if you are not transferring embryos into a uterus that you're stimulating that same woman, that the pregnancy rates are actually higher. What am I trying to say, for instance, is if you're doing an egg donation cycle, so the donor is the one that gets stimulated while the endometrium is being prepared on its own, and there's no stimulation going on in that ovary of the recipient, the pregnancy rates are often higher. Also, this is thought to be because the endometrium in the index cycle might be exposed to progesterone too quickly. So in other words, while you're doing your stimulation, before you want your progesterone effect to come in, there is some progesterone going on already. And in fact, on the day of on the day of egg retrieval, a lot of units do a progesterone level. And if the progesterone level is high, then they will actually freeze the embryos and rather transfer, and when the patient is not being stimulated. And that's the rationale behind that, is the fact that the progesterone in on the uterus might have started its influence before you want it to start. So the timing of the progesterone is important. And so in those, especially in patients that make lots of follicles and lots of eggs, there's a lot of estrogen and progesterone around, and that tends to affect what happens as far as endometrium is concerned. So usually you want your progesterone to come in, what we call for luteal support, before your embryo comes in, and you want to start that on the day of the egg retrieval or the day after. Or if you're talking about a frozen embryo cycle, then you time it. If it's a 5-day embryo, then you start like a day before, 6 days before you want to transfer. If it's a 3-day embryo, you start like 4 days before you want to transfer. So you're going to tell me that's easier. But in patients who you're stimulating at the same time, you worry about the effects of progesterone on that endometrial cavity before you want, your embryos to come in. So what about endometrial thickness and pregnancy rates? So traditionally, when you have when you're doing your scans and you're monitoring your follicles, we always check what the lining is doing. And when you have a thin endometrium on ultrasound during ovarian stimulation, it's been thought that it's associated with success rate. And the cutoff for thin is usually about 7.5 millimeters of thickness that we measure. And this, in a big study that was done in 2014, actually a systemic review and meta-analysis by Cassius et al. They found that only 2.4% of cycles had an endometrial thickness less than 7 millimeters. So in the bigger picture, it's actually not a big issue. In other words, there are very few patients that would have this problem. But in those cases where the endometrial lining was 7 millimeters or less, there was a trend towards lower pregnancy rates in those group of patients. And the conclusion was that endometrial thickness has a limited capacity to identify women with a lower chance to conceive after IVF. So in other words, there's not enough reason to think that if your endometrial lining is thin, that you couldn't possibly have a good outcome as far as IVF is concerned. So traditionally, we want the endometrial lining to be thicker, but in cases where you cannot get it to be much thicker, you could probably still go ahead and do your transfer and still expect to get a reasonable success or reasonable outcome from that point of view. What about fibroids? So I'm going to talk a little bit about fibroids. Fibroids are very common. If you practice in Africa or Asia or in South America, you'll see a lot of fibroids. Almost 1 in 3 women will have fibroids. And because they're so common, they tend to affect whatever we do as far as fertility is concerned. So there are different types. The 3 main ones and the fibroids in the cavity, which are the submucosal ones, the intramural ones, which are in the wall of the uterus, and then the subserosal ones, which are on the outside. The intracavitary ones, the submucosal ones, are the ones that really worry us because they sit in the cavity and they affect, your chances of implantation. And this, we always advise that, they should be removed, when you pick those up. And you could pick this up on MRI or ultrasound, whatever you decide to do. In a recent systemic analysis of about 5,000 patients, 15 studies included, there was a suggestion that non-cavity distorting intramural fibroids, so in other words, fibroids in the wall of the uterus that was not in the cavity or not distorting the cavity, still affected your live birth and your clinical pregnancy rates. So suggesting that, when you have these, you should probably remove those. But there is no evidence to say that if you do remove these fibroids, that you're going to improve the outcome. So that gets a bit confusing what I'm saying, but I'm talking from the scientific point of view now. In other words, the studies show that those fibroids that are not in the cavity but in the wall, perhaps close to the cavity, affect your chances of pregnancy following IVF. But removing them, there's not been enough big studies to confirm that removing them makes a difference in terms of improving your pregnancy rates. So I hope that makes a bit of sense. So to talk a bit further about that, it is likely that in women with smaller fibroids, it's not such a big problem. And in other words, the bigger your fibroids, the larger your fibroids, the more of a problem it is. So in other words, the other way to put that is that if you have larger fibroids and you remove them, you're likely to get a more beneficial effect than if you have smaller fibroids and you remove those. So you might not be able to tell the big difference with the smaller fibroids, but with the bigger ones, you would actually find that your pregnancy rates improve. But when you're trying to decide on whether you should, be removing them or not, there's a number of things to consider. The one is the cost of surgery, which if the medical aid is in pain or the patient is paying out of pocket, it could get quite expensive, whether you're doing it laparoscopically or whether you're doing it as an open procedure. It's important that, one considers the cost. There's obviously some downtime and when the patient has fibroids removed. So, morbidity of this pain, sometimes a fever, sometimes complications that could happen following, the procedure, even though they are rare, but one has to think about the possibility that it could happen in some cases. And then that means that there will be delay in your wanting to get that patient pregnant when you do remove the fibroids. So a number of things to consider. If the patient is a bit older, you might want to just rather do the IVF if you think the cavity is not really affected. In a younger woman with a bit more time, perhaps it's okay to go ahead and remove that. The other part to think about, though, is that when you do remove the fibroids, you are going to have some scar tissue in the pelvis and scar tissue in the uterus that could potentially also complicate things. So it's a decision that needs to be weighed up, on both sides, and then make that call. But definitely in patients with large fibroids and who've had previous unexplained, unsuccessful IVF cycles, you should probably consider having those fibroids removed. So in other words, patient has had an IVF cycle and it's failed a number of occasions with good embryos. And she had fibroids that are not in the cavity but have been ignored because they're not in the cavity. It might be worthwhile going back to remove those fibroids before trying further IVF cycles. What about polyps? So these are very common. These are probably the commonest things you're going to get in women, who are undergoing IVF. In women generally, if you do, hysteroscopies routinely, you tend to pick up more polyps than you will pick up, other pathology. So they're the most common pathologies found in the female reproductive tract. It's reported in up to 6 to 8% of women that are undergoing IVF in that study that was quoted in 2010 by Fatemi and by Karyalsin. Most physicians will perform a polypectomy in infertile women or in women undergoing IVF. So if the diagnosis is made in this group of women who are about to go for IVF or who are trying to get pregnant, most of the time, most physicians will advise that you have it removed. But there is limited data, and I will go through some of the data now regarding whether or not, if you do remove it, it makes a difference in terms of improving your success rates that way. So we'll go through that a bit. So in a retrospective cohort study, which refers to looking at things that had happened in the past. So retrospective refers to what's been happening before, and then you go back and look at those patients. This was published in Canada, and the impact of newly diagnosed polyps during IVF was studied, and this included about almost 3,000 women, 60 of whom had polyps. This was published in 2015. The overall positive pregnancy rates and clinical pregnancy rates and live birth rates, as well as spontaneous miscarriage rates, were similar in the group of women that had their polyps removed and in those who did not have the polyps removed. So, it looks like that big retrospective study will suggest that, looking at those parameters that I've mentioned, live birth rate, pregnancy rate, spontaneous miscarriage, there's not much difference whether you leave the polyp in or not. There was a twofold increase in biochemical pregnancy in the polyp group. The odds ratio is seen there. So in other words, you have more biochemical or unsuccessful pregnancies in the polyp group. So that might be the one thing that would, again, want to swing one in that direction. In another paper in 2011, also retrospective study, there was no difference in the polypectomy group compared to the control. So in other words, the group that had the polyps removed compared to the ones that didn't, again, no difference was shown. Another trial in 2012, they also had similar results in terms of pregnancy rates and live birth rates, comparing the two groups. But before this, several large studies have suggested a beneficial effect of a hysteroscopic polypectomy, in other words, going hysteroscopically, which is a minimally invasive procedure, removing the polyps prior to initial and after failed IVF cycle. So it's contradicting their cycle. There's studies that suggest that it makes a difference, and there are some studies that suggest that it doesn't. So the evidence is not overwhelming, but when you think about it, hysteroscopic polypectomy is a relatively minimally invasive procedure. So it's a procedure that most gynecologists now do as an outpatient procedure. So you come, you have it done, minimal anesthesia, maybe a bit of conscious sedation, if any, and this polyps could be easily removed in that kind of setting. So if there's a chance that it's going to affect IVF and you're going to spend that much money on IVF, one can argue that you should actually just have those polyps removed by your doctor prior to having the procedure done. What about intrauterine adhesions? So these are probably not as well known as a problem as far as patients are concerned. But these are bands of fibrous tissue which form within the cavity. Remember, the uterine cavity is like a little pear with a hole in it, and that's where the embryos implant. So if you have adhesions, like you've got bands between the walls on the inside of the uterine cavity, this you get following procedures, and the two commonest procedures that would lead to intrauterine adhesions would be one, myomectomies, whether it's laparoscopic or open, in other words, removing fibroids from the uterus, or two, evacuation following the miscarriage, what they call a DNC or uterine evacuation. And those are two things, the commonest things that will cause adhesions within the cavity. And so in patients who've had this, there's a higher risk of you having adhesions with the cavity. Excuse me. Fibrous bands like this could cause infertility as well as recurrent pregnancy loss, and could definitely affect your chances of IVF success, if they are present there. And so patients who had previous uterine surgery should have a hysteroscopy and removal of the adhesions prior to IVF. So you wouldn't know until you wouldn't see them on ultrasound scanner. It's very difficult to pick up in any other way. So if there's a history of previous surgery on the uterus, especially those two surgical procedures that I've discussed, you should go in hysteroscopically. The doctor should go in and have a look, make sure the cavity is clear. And if it isn't, take down those adhesions before further IVF is continued. And in a study by Fatemi in 2010, 2% of women who had routine hysteroscopy prior to IVF were found to have intrauterine adhesion. So even in women who did not have that history, that I mentioned of previous surgery, and who just routinely had, hysteroscopy prior to IVF, about 2% of them were found to have intrauterine adhesions. Not a lot, but obviously could be significant, going forward as far as pregnancy rates are concerned. So what about hydrosalpinges? Now, hydrosalpinges refer to blocked dilated fallopian tubes, which is usually as secondary to infection, or what we call PID, pelvic inflammatory disease. Um, so the infections are often silent in women, they're talking about chlamydia or gonorrhea, and it's usually in the past, so it's not usually an acute infection. But what it does is it, silently basically damages the fallopian tubes, which then gets blocked. So the ends of the tubes get damaged and they get blocked, and then fluid accumulates within those tubes, and that's what we call hydrosalpinges or hydrosalpings. And there's enough evidence, randomized control trials, demonstrating that if you have hydrosalpinges and you remove them, your IVF chances improve. So in other words, if you leave the hydrosalpinges behind and don't have them removed, then you tend to have, a decrease in the chances of getting, your IVF pregnancy success. And the thinking behind that is that the fluid, because it's from chronic infection and it's been there for a while, the fluid is a bad environment or causes a bad environment in the uterine cavity when you put the embryos back. So you put the embryos back in the uterus, but the fluid in those fallopian tubes is communicating with the endometrial cavity and then decreases your chances of implantation that way. So um, salpingectomies, if you have dilated tubes, salpingectomies is usually indicated. In other words, removing both tubes before you go ahead and do IVF. The problem is in areas, and we're talking about IVF now, but there are certain parts of the world where IVF is not freely available. And in those parts of the world, it's a problem because, once you remove these tubes, and these women cannot afford IVF, what then happens? In other words, you are looking at a situation where you remove their tubes and they're never going to get pregnant again once you've done that. So you need to make that call. If she can afford IVF, is the thing to do. If she can't afford IVF, you might just want to open them up and see what happens. However, during salpingectomy, when you're removing the tubes, you've got to be careful not to compromise ovarian reserve. So the blood supply to the tube is quite intimately related to the blood supply to the ovary. And you've got to take the blood supply away to the tube to be able to remove it without the tube bleeding. So while you're trying to do that, you might compromise the blood supply to the ovary as well, which means when you do IVF, the ovary does not respond as well to the stimulation as far as IVF is concerned. So again, it's something to think about when we remove them, but that's for the doctors to worry about. There are things we try and do to try and avoid compromising the ovarian reserve or the blood supply to the ovary when we remove those tubes. But the important thing to remember is that if you got dilated, hydrosalpinges or dilated tubes prior to IVF, you should have them removed, before surgery or before IVF is proceeded with. What about a uterine septum? This is a uterine anomaly, so you're born with it. It's the commonest uterine anomaly that one has. You could make the diagnosis by two-dimensional ultrasound or 3D ultrasound or saline infusion sonography, which refers to injection of saline while you do ultrasound. That makes it nice and clear. It makes it delineated a bit better. You can sometimes pick it up on HSG, which is hysterosalpingography, and sometimes on MRI. But these are obviously things that are done in different parts of the world for patients who are trying to conceive. And if you do pick them up, the question is, what do you do with the septum? They may cause spontaneous abortion, recurrent miscarriages, preterm delivery, and implantation failure. So they could be a concern. Often what's quoted, though, is that if you look at women who've had normal, successful pregnancies, the incidence of uterine septum is about the same as in women who have those problems that I've elucidated there. So the question is, if you remove the septum, does it make a difference? number of studies have been done to try and check. But generally speaking, if you have a patient who's at IVF failure, or who has an obvious long septum, then those patients should have the septum resected. It's a really relatively straightforward thing to do. It's done hysteroscopically, again minimally invasive, and you basically just trim the septum to try and get a normal cavity from there, prior to the patient having her IVF cycle. So if the septum is present and there are problems with conceiving, then one should consider removing them. What about altered microbiota? So we all realize that the endometrial cavity has its own unique, sort of organisms that stay there, or microbiome. In a study of 35 infertile women undergoing IVF, the presence of non-lactobacillus prevalent microbiota, in a receptive endometrium was associated with decreased implantation. So a certain kind of bacteria that was absent, made it less likely that implantation and pregnancy would actually occur. That was a study published in 2016. We need larger studies, to try and explain this. But basically, if you have altered sort of, microorganism level or microbiome in the endometrial cavity, there's a chance that, it affects your success rates, that way. A lot of talk, especially in the last couple of years, has gone on regarding whether if one does endometrial sampling, or what we call endometrial injury, or scratching rather, of the endometrium prior to doing embryo transfer, that you probably improve, the chances of success. There were initial small studies that went along with that. But let's examine what the big evidence says. So the feeling is that a month, or in the month preceding the time you're doing the IVF, if you go in and do a bit of endometrial scratching with a curette, or with a hysteroscope, that you might improve implantation rates that way. However, in a systematic review and meta-analysis in 2015, included 14 trials, over 2,000 women, considered to be moderate quality evidence that endometrial injury is associated with improvement in live birth rate in women who have had more than 2 previous embryo transfers. So in that particular group of women who've had more than 2 previous embryo transfers, if you do this sort of endometrial scratching or endometrial injury, you might, get some kind of response. I must say there are other studies who more recently that have suggested that you probably are not going to get much of of joy from doing this. But if you do it outside the cycle, in other words, prior to the cycle, it doesn't do any harm. And so it might be something one wants to consider in patients who've had recurrent, failures as far as implantation is concerned. The procedure is mildly painful, and it should definitely be avoided on the day of egg retrieval, because that's been associated with lower pregnancy rates. If you're going to do it, it has to be at least a few weeks prior to the embryo transfer, or to the index cycle. So what about just hysteroscopy in patients who've had recurrent implantation failure? So in patients who've, you've transferred embryos quite a few times and they're just not implanting, and who have normal endometrium on ultrasound scan, hysteroscopy is often advised. So usually you will do that. You've done a scan, you're not picking up anything. Is it worthwhile going to do a hysteroscopy in these women? And the answer is probably not so clear cut. So in a multi-center trial involving over 700 women, all of them aged less than 38, who had 2 to 4 prior failed IVF cycles, the live birth rate was the same, about 29%, in groups that are assigned to hysteroscopy and in groups that did not have hysteroscopy. So in this group of patients who've had recurrent pregnancy losses, or sorry, I rephrase that, recurrent IVF failures, you're probably not going to benefit much if you go and do hysteroscopy on them. Having said that, it depends on how good the ultrasound that you're using is. So if you've got a very high resolution ultrasound scan, that is very good. You'll be able to pick up things anyway. But if it's an older ultrasound scan, you might be missing things. And in this group of patients, maybe hysteroscopy, should be considered. So that trial will suggest that if you don't identify things on ultrasound scan, you're not going to pick it up on hysteroscopy. But like I said, it depends on the availability of high quality ultrasound scans. So if you practice in an area where every gynecologist or fertility specialist has very high resolution ultrasound scans, that will be enough to pick up pathology, I would think, in those patients. So these are the concluding remarks. So many things can happen. So many things can go wrong as far as the endometrial cavity is concerned. Generally, if you don't look, you don't find. So while we're concentrating on the embryos and the quality of the embryos, in other words, the quality of the sperms and the eggs, we should also be thinking about the endometrium all the time. It's just as important as far as successful IVF is concerned, and should be interrogated, especially in the face of recurrent failed cycles. So you should definitely consider doing a proper ultrasound initially. And in patients who've had failed IVF cycles, it might be worthwhile investigating it even further. The timing of the embryo transfer is very important, and I've mentioned that right at the beginning. It might be worthwhile, in fact, there are some cycles, some centers in the world that all they do is a freeze-all cycle. In other words, they never transfer during the stimulation of the pregnancy of the woman that particular time. They would always get embryos, freeze them, and then transfer in a natural cycle the following month, or even remote from the time that the patient has been stimulated. And the feeling is that you just avoid that progesterone effect being in on the endometrium quicker than you actually want it to be. To realize again, hysteroscopy is a minimally invasive procedure. Can be done, like I said, outpatients, quick to do, and it might be something one should consider, especially in patients who've had recurrent implantation failure. With this, I'd like to thank you for listening to me, and to again welcome you to Cape Town whenever you are opportune to do so. Thank you so much.
And thank you so much for bringing this topic, definitely interesting topic to discuss. And so thank you so much for bringing this, but also for explaining all the details that you have just provided. So thanks a lot. And of course, as you can see, there are plenty of questions ready for you. So are you ready to
Yeah,
answer them? All right.
let's do that. Yes. Mhm.
Happy to hear this then. And let's have a look. Of course, there are questions ready. The first one is a bit of a longer question. So I just removed a polyp 2 days ago. It was located on the back of the uterine wall, so it was pointless to remove it given the data showed in your presentation. Also, what if it grows back? Is it worth it to remove it? I never had IVF or miscarriages. I'm 43 and I will have donor eggs IVF hopefully within 2 months. Can I have a transfer after 1 or 2 months from the removal? Thank you.
Okay. All right. I'm going to answer that question from the back. So yes, you can have your transfer 1 or 2 months after the removal. I would think that's enough time for things to happen. It's a good thing you're going with donor eggs. At 43, I think your chances are much better that way. So, like I said, the evidence is such that I guess it depends again on the size of the polyp, perhaps. But if it was picked up, if you remember, I mentioned earlier that most IVF units will still, remove the polyps. If it was picked up on routine investigation, like 2 centimeters, yeah, so that's a good size. If it was picked up at the time, you were being investigated for the cycle, I think most of us will probably not ignore it. A 2 centimeter one will be one that we will probably go after and have it removed. So I think it was a good move to have the polyp removed, hysteroscopically, and it didn't go back so quickly. So you got yourself a bit of time to try and get your IVF cycle done. After you've had after you have the polyp removed. So good luck. I hope that answers the question.
All right, excellent. Thank you so much for answering that question indeed, and of course for your question. Next question also is ready. How could removing a lot of small or big fibroids in the uterus in the wall near the uterine cavity could it affect fertility? What is the best method to remove them and preserve fertility?
Yeah. So it could. I mean, I might have mentioned in my talk as well that you're going to cause scarring, of the uterine muscle. So you're going to toss up between the sizes of the fibroids, and the proximity or the closeness to the cavity. That's what makes you decide whether you're going to operate or not. Once you decide to operate, we follow all the standard protocols. You go quickly, you try and prevent adhesions, but you are going to get scarring. So the question is whether if you operate on this uterus and you remove the fibroids, are you going to convert that to a potentially fertile pelvis to a non-fertile pelvis, or fertile uterus to a non-fertile uterus? I think generally speaking, we do a lot of myomectomies. We do a lot of fibroid removals, and following that, most patients conceive either on their own or following IVF. So if it is indicated and it's close enough to the cavity, yes, it should be removed. Could it affect fertility? Potentially, it could affect fertility, but it shouldn't actually. In other words, if you decide to remove it, it's because you're hoping that it would actually be better. So in other words, you're expecting that your fertility chances would actually be better afterwards. The best method to remove them depends on a number of factors. Depends on the surgeon, the experience of the surgeon. It depends on the location and the size of the fibroids. If the fibroids are in the cavity, the best way to remove them is hysteroscopically, in other words, going through the cervix into the uterus and removing them. If they're in the outside wall and they're big, you have to go from the top. So in other words, you either have to do it laparoscopically or you have to do a fairly big incision to remove them, depending on how many you have. So the decision on how it's removed depends on a number of things, and obviously on your doctor and the patient as well. I hope that answers that question as well.
And excellent. Once again, thank you so much for your question. And of course, thank you for the explanation to this. And there's a thanks from the patient for you as well. All right. Next question also is ready right here. So thanks for your presentation. Want to start the IVF process and went for the first scan, and it was found that there was a 2.6 centimeter submucosal fibroid. Is it necessary to remove the fibroid surgically before going for the IVF, or is the size insignificant?
Oh yes, it's definitely significant. I mean, 2.6 centimeter, if it's submucosal, in fact, if it's a 0.5 centimeter submucosal one, it is significant. So if you've started the IVF process, I'm assuming you're talking about having gone through the stimulation process already. If you've gone through the stimulation process already, I would freeze the embryos. In other words, I will go ahead, do the retrieval, fertilize, and freeze, and then go and deal with this, fibroid before embryo transfer. If it's just in the workup stages of the IVF and the stimulation has not been started, then this should be dealt with or could be dealt with relatively quickly and then go and complete the cycle. So it is necessary if you've got a 2.5, 2.6 centimeter submucosal fibroid, it will be necessary to have it removed prior to IVF.
And thank you so much for that advice as well. Okay, next question is, so does a retroverted uterus affect IVF success rate?
No, it really doesn't. I guess the only part of it that could be a problem is during embryo transfer. So in other words, when you're trying to get the embryos in with the help of a catheter, and sometimes with a retroverted uterus, it might be a bit difficult to get into the cavity. But generally speaking, there are ways around that, that we try and, we might put a little clip on the cervix and pull it down a bit. And once you get the embryo into the cavity, the chances are the same as if you have an anteverted uterus. So it's just about getting the embryos into the cavity, and usually in an experienced situation, it's not a problem. Most doctors are able to get the embryos into the cavity. So the short answer is no, but the only slight caveat there will be there might be difficulty in getting the embryos into the endometrial cavity in a retroverted uterus.
Thanks a million for yet another advice, of course, and as well as your question. And there's a thank you from the previous patient and from this patient for you as well for your answer. Next question is up. I have regular ovulation, but often I have thin endometrium, 6 to 7 millimeters. Next month I will have frozen embryo transfer. Is using few days estrogen support right after ovulation a good idea? If not, what can we do?
Oh, that's a good question. Yeah, so I mean, like I mentioned, 7 millimeters is something you kind of worry about. Um, and those are one of the things you can do is to use some estrogen support right after ovulation and keep going with that, you know, until the point of embryo transfer and perhaps even up to the point of a pregnancy test. Now, whether this would make a difference or not, there's probably not enough studies to sort of confirm that, but it shouldn't do any harm. So, it would be something that I would definitely consider in a patient who's going for a frozen embryo transfer. I'm assuming this is a cycle in a natural cycle. The other thing to try and do in this kind of scenario is to downregulate the patient, and then try and build the lining up, you know, individually. So you take over the building of the lining itself, and then in that case, you can increase the level of estrogen significantly before you put the progesterone and try and get the thickness. So it depends on what kind of cycle your IVF center uses for FETs. It could be, if it's a natural cycle, what you're saying now makes sense to put a bit of estrogen in before, to try and get it to improve. If it's using a completely taken over cycle, then in those situations, you can actually drive up the estrogen level significantly and try and get the lining to get a bit thicker that way. So it might be something to suggest to your doctor.
And thank you again for this advice indeed. Okay, next question is also right here. I had open fiber surgery 4 years ago. New fibers have grown back. Should I remove them again with open myectomy? How could I prevent them to grow back after surgery? How could I shrink them if I don't want another surgery?
Okay, so I mean, I'm assuming we're not talking fertility here. If we're not talking fertility and it's just the symptoms following fibroids, then there are other options. One of them is uterine artery embolization, which is available in most parts of the world, where the blood supply to the fibroids are identified and they are embolized. So we put little particles that block the blood supply. And if it is for fertility, it becomes a little bit trickier. Uh, and if it is for fertility, you might have to actually have it removed again if it is in the cavity. So if it's close to the cavity or it's in the cavity like the fibers I described earlier, then it makes sense to have a reoperation to have it sorted out again, and then but not wait. In other words, have it done and go straight into IVF or ART, straight away. How do you prevent them growing back? Unfortunately, there's very little one can do to prevent to prevent fibroids from going back. Um, if you don't want another surgery, you can perhaps consider using the medication like Zoladex, which you can use a GnRH agonist that could help shrink the fibroids, but that's only temporary. The moment you stop that, it will grow back again. So you might be able to shrink it for a short while and then go into an IVF cycle and get that done that way if you want to. It depends again on how big they are, how close they are to the cavity. So many other factors, have to be considered. But to the short answer is you might need reoperation if the fibroids have grown back in a place where it's going to affect, fertility. You can consider using GnRH to try and shrink if we think shrinking it will then take it away from the cavity completely, which is unlikely. But there are very few other options. Uterine artery embolization I was talking about earlier is usually reserved for women who are not trying to get pregnant at that particular point in time, and it does work effectively in shrinking the fibroids. But if you're trying to conceive, then you're left with either reoperation or having GnRH agonists to try and shrink it initially The question is whether that will shrink it enough for you to be able to do IVF successfully.
All right. Once again, thank you so much for yet another thorough answer to this question. And of course, there's a thank you from the patient for you as well. Next question is also right here. So I had sonohysterosalpingography, sorry, and they found both tubes blocked proximally. After a hysteroscopy, they saw the entrance of the tubes. There were holes, but they couldn't say if they were patent or not. How can one diagnose hydrosalpinges and not with hysteroscopy? I think. Then how?
So, again, I'll answer the question at the bottom first. Um, Hydrosalpinges are diagnosed on hysterosalpingography, usually. Um, Proximal blockage means, right at the beginning of the tube is where the blockage is. So even if there's a hydrosalpinx, you probably wouldn't be able to get the dye to go that far because the tube is blocked anyway at the beginning. Hydrosalpinges refer to blockage distally. So in other words, it goes into the tube and then the fluid gets to the end of those tubes and then it gets swollen there. It doesn't come out because the tubes are blocked at the end. So the hydrosalpinges are usually distal blockage rather than proximal blockage. So if you got proximal blockage, it's a bit difficult. Like you say, you might have to repeat the HSG at some point to see if it's been opened, if they tried to. I'm trying to piece together what you're saying here. Did they try to put a catheter through to try and open the proximal blockage? If they did that, then you might be able to on HSG actually see that it's open. If they haven't been able to successfully do that, then you're looking at IVF. But if there's proximal blockage, then you do not have to remove the tubes. You can go straight into IVF. So you're saying, how can they see if I had proximal? Maybe try to push the liquid, but nothing happened. So there are two scenarios there. It's possible that it is blocked proximally and that might be the reason why it's not going through. The second possibility is that you might have had spasm, what we call conal spasm. So the tube might actually just be in spasm at that particular point, and that's why the dye didn't come through. You've got two options here. Either you repeat in a couple of weeks' time, you can do it. I know it's quite uncomfortable and sometimes painful, or you can have a laparoscopy done. And at laparoscopy, we try and do what we call laparoscopy and dye. We introduce the dye through the uterus, and then that will be a second test to try and check if the tubes are open. If the tubes are still blocked on laparoscopy and dye or on repeat HSG, then it is clear that the tubes are indeed blocked and you have to go for IVF. And if they are open at that point, then you've got your answer. So that's how it's diagnosed.
All right, thank you so much. And as you can see, our patient actually added here, yes. So how can they see it? If I had a proximal blockage, they tried to push the liquid, but nothing happened. And sorry, there's another follow-up. Yes, they told me I might have had spasm, but I took a medication to relax muscles. Is in laparoscopy a bit invasive? I'm still the 43-year-old woman.
Sure. It is a bit invasive because it needs general anesthetic, and obviously we need to make little holes in the tummy with the camera. But it's also safe. In other words, we do a lot of laparoscopies. People, most fertility units, this is bread and butter as far as they're concerned. They just do this all the time. So it's relatively safe, not without its complications, obviously. So it's still something one can consider if you're trying to get the answers. Yes, the fact that they gave you something to relax, like Buscopan and all that, is indicated to try and see if that helps with the spasm. But that doesn't always mean that there's still no spasm. So, in other words, the fact that you used the medication and the tube still remained blocked does not mean that it still wasn't spasm. There could still have been spasm. That's why laparoscopy is indicated. The risk of adhesions with laparoscopy is not high. With a simple laparoscopy, the chances of causing adhesions is actually quite slim. If we do more work, in other words, if you have endometriosis, which wasn't diagnosed before, or adhesions previously, then you might cause more adhesions. But just a simple, straightforward laparoscopy to check your tube should not really induce too much adhesion. So I don't think you need to worry too much about that.
And wonderful. Thank you so much for that question, and of course for your thorough answer to this as well. And there's a thank you from the patient, but also there's a follow up. Okay, sorry, let me
Yeah,
just go straight to it.
come on to
So,
justify the laparoscopy. So yes, I mean the most if you have a hydrosalpinx, a laparoscopy is almost always indicated because you need to then remove or at least block those hydrosalpinges, and that's usually done laparoscopically. So like I said, it's invasive, but it's safe, and we do a lot of it. So I don't think you need to worry too much about that.
and thank you for the reassurance here as well.
Mhm.
Next one, but if I don't know and it's just to check.
Yep. If you so like I said, if the HSG is not giving you the answers, then the next step will be a laparoscopy to check. There's no problem with the questions, no issues.
No problem, of course, whatsoever.
Mm.
Thank you so much for the questions, indeed, and of course, your help with that. Let's have a look, of course, at the next question. There are a few questions left. So, is there an age limit for treatment in your clinic? Is surrogacy or egg donation an option?
Yes, there's no age limit per se, but obviously above the age of 42, we would advise that you probably should consider egg donation, which is freely available here. Surrogacy is a little bit more tricky. It is available. When I say tricky, I mean that you do have to have a you have to have a high court judge saying that you can have surrogacy in the country. Your doctor needs to write a letter, lawyers need to write a letter. So it's a little bit more complicated, but it's definitely possible. We can offer that service. Egg donation is a lot very freely available. And so above the age of 42, 43, you're probably looking more at an egg donation cycle rather than a normal cycle. But it's freely available, yes.
And perfect. Thank you so much for the clarification to this question as well. Next question is, so how much is estrogen involved in the growth of fibroids and polyps? Is there a way to prevent the estrogen to have such an impact on these formations?
Mhm. It's a good question. Estrogen, these are all estrogen dependent tumors. So they all grow on the basis of estrogens. But you need estrogens everywhere else. You need estrogens on the breast, you need it on the endometrium, you need it on the skin. So you don't really want to block, production of estrogens. It's just that they have different effects on different organs. Some good and some not so good in the case of polyps and fibroids in the uterus. But it's not just estrogens because every woman has estrogens, but not every woman has fibroids and polyps. So there are other reasons why you would then develop fibroids, which is genetic factors, and other factors, but perhaps even in the diet, which we don't know too much about. So it's not just about the estrogens, and just so we can't just shut down all the estrogen production because then you shut down all the good effects of the estrogen as well. So you can't really do that. So you have to look for ways of treating the condition rather than trying to just block the estrogens. And the fact that you block the estrogens does not mean that you're going to prevent those conditions anyway. So yeah, so we just treat the fibers and the polyps, but it's almost impossible to. In some circumstances, we try and shut down the estrogens completely, but you can't do that forever. You can do that maybe for a short while, because if you do that going forward, then you have other factors as well: osteoporosis, cardiovascular disease, and all that comes with lack of estrogen. So you need your estrogens.
And thank you once again for yet another answer. And of course, thanks a lot from the same patient for you. Okay, let's have a look at the next question that we have. So, for egg donation process, what medication would you suggest to help improve the thickness of the uterus for successful egg donation IVF process? What is a good thickness size?
So starting with the second question, we aim for anything from 8 millimeters or above. So you want to get at least over 7.5, 8 millimeters. And I mentioned earlier that you need to stimulate with estrogens. After downregulating, it gives you the ability to increase the dose of estrogen significantly. That's probably the one proven way of doing it. You can give the estrogens vaginally. Some people have used Viagra to try and improve, the lining of the uterus, and a few other sort of non-proven things. But usually, it's about increasing your estrogen levels and trying to get those levels to a level where the endometrium then responds to it. So you might, for instance, some women might require only 4 to 8 milligrams of estrogen per day to get things going, while in some women you might have to go to 12 milligrams and stuff to try and get the lining that you require. So that's how it works. You downregulate, you then stimulate with estrogens until you get to the lining you want, and then you throw the progesterone in. So that's what we use. But there are other things one can consider, other sort of non-proven, like I said, procedures that can be considered to try and improve your chances of a thicker endometrium. But usually it's just the use of estrogens to try and get it going.
And thanks a million for yet another question, and of course your help. Next question is: so, do you think about subserosal? What do you think about subserosal 5 centimeters fibroid located in the isthmic area? There is only 3 millimeters from fibroid to endometrial cavity. Does the fibroid makes implantation more difficult or influence somehow the pregnancy?
Mm. It's a tough one. I mean, 5 centimeter is probably a cutoff where most people would think it might be worthwhile still removing that fibroid. You've got two conus, so if it's close to the isthmic area, the other isthmic area is there, and the tube should work from there. If that's the only problem, in other words, you should be able to get pregnant with the other tube if this is going to be a problem. 3 millimeters from the endometrial cavity is close, but it's again not the closest. So if you have an implantation difficulty, in other words, if you have tried IVF and it's not working, or you've been trying to conceive for a while and everything else is fine. So in other words, the sperms are okay, the tubes are fine, and the only thing they can find is this 5 centimeter fibroid, then I think that should be removed. But only in those circumstances, so generally, this is probably not one that we will go after. But if you've had implantation failure with good blastocyst or good embryos and it's not working, or just trying to conceive over a period of time and it's not working, then it might be worthwhile, and everything else is okay, it might be worthwhile going back to have this removed.
And once again, thank you so much for the explanation. There are like 3 questions left, so we will be slowly
Okay.
finishing. And the question is: so, my gynecologist diagnosed me with mild form of adenomyosis. What is the possibility that I have also endometriosis? On ultrasound, it is not seen. Soon I will have hysteroscopy done. Do you suggest laparoscopy? Thank you very much.
That's a very good question. Yeah, so malform adenomyosis in about 1/3 of cases would also have endometriosis. If you're having a hysteroscopy done and you don't have any symptoms at all, you can argue that you do not have to have a hysteroscopy, but a laparoscopy, sorry. But if you're trying, I'm assuming you're trying to get pregnant. So that's the first. So you're trying to get pregnant and you're not getting pregnant. And especially if you have other symptoms like painful periods or longer periods or just difficult periods or pelvic pain or pain during intercourse, if you have any of that along with it, then you should have a laparoscopy as well. If so, it's difficult for me to know what your gynecologist meant by mild form of adenomyosis. Maybe he's not sure about adenomyosis and he just wants to do a hysteroscopy, and that's fine. So you could just do the hysteroscopy provided you don't have any other symptoms. But if you got symptoms of, suggestive endometriosis, like I mentioned, then you should consider a laparoscopy at the same time. I hope that answers the question.
Wonderful. Thank you so much once more for that. And there's a thank you from the previous patient as well. Next question is I never checked my progesterone levels in the luteal phase. I usually have light spotting 3-4 days before my period, and my breast hurt a lot from after ovulation till the period. Does this may be an indication of a hormonal imbalance between estrogen and progesterone? Maybe low progesterone?
I don't think so, clearly. I mean, I think some women do have a bit of spotting a couple of days before their period starts. It doesn't actually indicate that the progesterone levels are high or low. Breast tenderness around this time, again, it depends on how sensitive those breasts are to progesterone. Some women's breasts are more sensitive than others. And a few days before the period, you might find that you do have, quite tender breasts. It doesn't actually indicate an imbalance between estrogen and progesterone at all. It's just that your system, responds differently to those hormonal changes, which is completely normal. So I don't think it's naturally low progesterone or an imbalance in the estrogen progesterone balance.
And excellent. Thank you so much once more. Okay, next one, it's actually a follow-up, and it seems that that might be our last question for today. So do you suggest checking the progesterone in luteal phase before having IVF egg donation?
So in egg donation, not, because in most cases of egg donation cycles, you are already, you're down regulated, so you've already got a GnRH agonist or something, Leucine or Zoladex to tridentine. So we don't have to worry. The progesterone only comes in when we introduce the progesterone. So we don't check in the luteal phase the progesterone levels. We just check the lining. That's because you basically it's an artificial cycle. You're down regulating and then stimulating with estrogens. And progesterone is coming in just to get the lining ready at that particular point in time. So no, we don't actually do that in the luteal phase with an egg donation cycle. In the index, if it's a normal IVF cycle, then yes, then you need to, like I've explained before, you on the day of transfer or of retrieval, you might check the progesterone, and if it's high, then you don't transfer. But with egg donation, it doesn't matter. You already covered that base.
And wonderful. Thank you so much once again. As I mentioned, it seems that that was our last question, final question for today. And as you can see, there are some of the thank yous coming up your way right here. So thank you so much everyone for your questions. Indeed, quite interesting and of course very detailed ones. So thank you so much for that. And also, as you can see, there's a thank you so much for your very good presentation, help with our questions. Thank you.
Absolute pleasure.
And I just want to mention as well that I have just sent you a link where you are able to get in touch with Dr. Femi and his team. And if you do that, and of course, I'm sure they will be more than happy to help you out with some of more of your questions and of course some more details. And Dr. Femi, thank you so much once again for joining us,
Thanks,
for
Caroline.
answering all the questions. And before I let you go, please let me know if you would like to add anything else.
No, it's been a fantastic. I mean, people have been very, very involved, so I've totally enjoyed it. It's always good to be able to interact with people. Thanks for having me on. I'll be happy to do this again sometime. Thank you.
And we are definitely more than happy to have you back. And I definitely hope we will be able to have another webinar, another session, interesting session
Sure.
with you. And of course, as you can see, more of those comments are coming up. South Africa is awesome.
Yeah.
Thanks for the great presentation. Well, couldn't agree more here. So thank you so much, everyone, for joining, for your time. And Dr. Femi, also, thank you so much. It is quite late for you. So have a
Yes.
pleasant evening. And the rest of you, I do hope to see you tomorrow as we will be back with another session. So just join us at 8 p.m. UK time tomorrow. And
Sure.
let me just mention, of course, as always, it has been recorded, so you will be able to find the session on myivfanswers.com. And if you subscribe to our channel, YouTube channel, My IVF Answers, that way you will know that when the video has been uploaded. So I can only encourage you to go ahead and do it. And once more, thank you so much. Have a lovely evening, everyone. And
Thank you.
Dr. Femi, till our next event. Thank
We'll
you.
chat. Thanks,
Take
Caroline.
care.
Cheers.
Bye.
Bye-bye. Bye. Bye.